Welcome to the Deep Dive. We're here to break down complex source material, really give you that shortcut to mastery. And today, we're diving into a really demanding field, pediatric critical care. This is an area where your patients are incredibly vulnerable, their physiological reserves are minimal, and frankly, the margin for error is just razor thin. Our goal today isn't just, skimming the surface of resuscitation protocols. No, we want to go deep. We're looking at the whole comprehensive framework that guides the absolute top professionals. Everything from, say, the physical layout of a specialized unit, all the way down to the molecular mechanics of shock. We really want you to grasp the logistics, the precise physiological principles that govern care for these critically ill kids. Okay, so let's unpack this. Let's really aim for that level of understanding, that operational excellence.
That's exactly right. And for you, our listener, think of this deep dive as building that core foundation needed to optimize child survival. Because true mastery here, it really requires understanding the why behind every protocol, not just memorizing the steps. So our discussion today is kind of structured around two main pillars, you could say. First, there's the operational side excellence in the Pediatric Intensive Care Unit, the PICU. That includes its design, logistics, how resources are managed. And second, mastering that time-critical clinical decision-making. So the systematic ABCDE approach, the PALS protocols, and importantly, specialized shock management.
Okay, let's start with the physical space then, because the environment itself, that's really the first line of defense, isn't it?
Absolutely.
In any large tertiary care hospital, having critical care capacity isn't optional, it's essential. And our sources suggest this usually translates to about, 5 to 10% of all pediatric beds being dedicated PICU beds.
That's the typical range, yeah. And that percentage, it climbs higher, sometimes significantly higher, if the hospital handles a lot of complex surgeries that need that close post-op monitoring.
Right. And this points to something maybe unexpected, how much sheer space matters. The sources are really specific here. They mention an optimal PICU size is maybe 6 to 10 beds. But the really striking detail is the area needed per bed.
It is striking. You need 250 square feet for each bed space.
Wow, 250 square feet. That sounds like a huge amount for, a small child. Why is that specific number so critical? What makes it the difference in a crisis?
It's all about access. Unimpeded, rapid access. That square footage guarantees enough room for the whole team, doctors, nurses, respiratory therapists, plus all the bulky equipment. But most importantly, like you said, in a crisis, it ensures immediate, clear access to the patient's head end.
For airway management.
Exactly. For emergency airway management, where, literally seconds count, if you're fumbling, pushing equipment aside to intubate, the design itself has failed that patient.
Okay, so space is key for access. Beyond that, stable operations depend on utilities. We're talking basics, but absolutely critical ones.
Foundational infrastructure, yeah. An uninterrupted power supply, for instance. That's not a luxury, it's mandatory. You can't risk losing ventilator support or critical infusions during an outage.
Makes sense. And air conditioning. For herd, I see. Not just for comfort.
Right, it's about thermoregulation in vulnerable kids. And, of course, centralized monitoring is essential. You need constant, simultaneous oversight of every single patient from a central station.
And the hardware backing this all up needs to be pretty extensive, too.
Oh, absolutely. The required list is all about continuous, intensive monitoring. You need cardiorespiratory monitors, ECG, pulse oximeters, mechanical ventilators, nebulizers, infusion pumps, lots of infusion pumps for precise drug delivery.
And quick lab access is fundamental, right? Blood gases, counts, glucose.
Definitely. But the materials also highlight things like portable X-ray and ultrasonography units. They're noted as highly desirable additions.
So they're optimizing tools, bringing diagnostics right to the bedside, speeding things up.
Exactly. They boost diagnostic speed right there without moving a fragile patient.
This level of resourcing is, it's immense. Which brings us to the next point. Who gets access? Especially if resources are limited, how do top centers decide? How does that gatekeeping work?
Yeah, that's a critical question. It forces strategic resource allocation, and it has to be governed by very clear admission triggers. The sources outline these, and we can group them into about 6 main categories.
Okay.
This ensures the kids who most need this high-level intervention get it promptly. First category, hemodynamic or circulatory crisis. This is any immediate threat to perfusion. So think shock needing inotropes, severe blood loss needing transfusion like severe anemia or hemorrhage, dangerous cardiac arrhythmias, or obviously full cardiorespiratory arrest.
Okay, direct perfusion threats. What's next?
Second is respiratory failure. This covers a spectrum, from severe distress needing oxygen all the way to impending or actual failure that requires mechanical ventilation.
Got it. Then neurological issues.
Third, yes, Neurological emergencies. We're looking for significant changes in consciousness, maybe from encephalopathy, or life-threatening events like ongoing seizures, status epilepticus, or any signs of dangerously high pressure inside the skull, raised intracranial pressure.
Okay. And then the body system's just breaking down.
Right. Fourth category, organ failure and metabolic chaos. This includes acute liver or kidney failure, severe electrolyte problems like dangerous potassium or sodium levels, really low blood sugar, uncontrolled diabetic ketoacidosis, or acute poisoning where you need close monitoring for complications or antidote effects.
Makes sense. And the last two, infections and procedures.
Exactly. Fifth is severe infections. These are really common triggers worldwide. Think severe malaria or severe pneumonia, where the infection itself often leads to respiratory or circulatory collapse. And sixth, interventional or post-procedural needs. This could be close monitoring after major surgery, or kids undergoing things like peritoneal dialysis, exchange transfusions, or needing central line placement. These last ones might seem stable initially, but the potential for rapid deterioration means they need that intense PICU surveillance.
All right, so once a child needs critical care, the focus shifts instantly from the room to the patient. Assessment. Now, before we even get into the standard ABCDE approach, there's an immediate check for a child who's unresponsive. What's that very first critical step?
Yeah, that initial action is crucial. For an unresponsive child, you check two things instantly. One, are there any breathing efforts at all? Are they gasping or just apneic, not breathing? And two, are central pulses present or absent, carotid or femoral pulse? And the key here is the immediate decision point. If they have abnormal or absent breathing and no central pulse, you don't waste time on further assessment. You start CPR immediately.
Okay, so CPR first if they're essentially lifeless. But assuming we don't have immediate arrest, we move to the systematic ABCDE approach, that rapid primary survey.
Correct. It's designed to find and treat immediate life threats in sequence.
So A is for airway. How do we categorize that?
You look at it in three ways, basically. Is it clear and open? Is it maintainable, maybe just with simple maneuvers like a chin lift or a jaw thrust? Or is it not maintainable, meaning you need an advanced airway right now?
Got it. Then B for breathing. What are we assessing there?
For B, you're looking at the work and effectiveness of breathing. What's the rate? How much effort are they using? Any retractions, nasal flaring? Listen for abnormal sounds, wheezing, crackles. And of course, check oxygen saturation with a pulse oximeter, the SpO2.
Okay. Now, C for circulation. This seems like the most detailed checklist. It's more than just a pulse, right?
Oh, much more.
Yeah.
You need a full picture. Skin color, is it pink, pale, mottled, cyanotic? Skin temperature, warm or cool peripherally. Then heart rate and rhythm. Blood pressure, if you can get it quickly. And crucially, compare central pulses, like the femoral, to peripheral pulses, like the radial or pedal. Are the peripheral ones weak or absent?
And capillary refill time, CRT.
Yes, definitely measure CRT. Press on the skin, see how fast the color returns.
But circulation assessment isn't complete without checking if the organs are getting enough blood flow, right? And organ perfusion.
Exactly. That's vital. You assess two main things. The child's mental status that tells you about brain perfusion. Are they alert, irritable, lethargic, unresponsive? And their urine output. That's your window into kidney perfusion. Low urine output, oliguria, is a huge red flag that circulation is failing, often before the blood pressure drops.
The silent alarm from the kiddies.
Okay.
Then D for disability.
D is about neurological status. Establish the level of consciousness quickly. Usually the AVPU scale alert responds to voice, responds to pain, unresponsive, or, if time permits, the more detailed Glasgow Coma Scale, GCS. And couple that with checking pupillary response to light. Are they equal, reactive? Gives you a quick neurological baseline.
And finally, E for exposure.
Right. You need to fully expose the child, briefly, to look for hidden clues. Maybe a non-blanching rash suggesting something serious like meningococemia or signs of trauma, injury marks, bruises. But critically, you have to cover them back up immediately afterwards to prevent hypothermia. Exposure must be quick and followed by warming.
Okay, that systematic approach makes sense. Now, you mentioned something fascinating earlier, the focus on subtle danger signs, especially in infants.
Yes, this is incredibly important for mastery. Children, particularly infants, can compensate remarkably well for a long time until they suddenly crash. So clinicians need to be hyper alert for these subtle danger signs that predict serious illness, often before the classic ABCDE findings become obvious.
So these are the early warnings, the red flags that say intervene now. What are some examples?
Things like any seizure activity, an inconsolable cry. Is it pain? Is it neurological? Decreased activity, lethargy, drowsiness, that's a big one. Any obvious increase in the work of breathing, flaring, grunting, retractions. Abnormal breath sounds you might hear without a stethoscope. Or pauses in breathing, apneic episodes.
And signs of poor circulation.
Yes, systemically. Cold hands and feet, especially if the room isn't cold. Decreased urine output, as we mentioned. If they're not feeding well, or if they have bilious green vomiting, that's always concerning. Any one of these signs suggests the child might be in compensated shock or heading towards serious trouble. Missing these is often the difference between early intervention and facing an irreversible collapse.
All right, so the child is now in the PICU. Initial stabilization is underway. Monitoring shifts from that quick survey to continuous high-fidelity tracking. Let's start with breathing. Beyond just watching rate and pattern, how do we monitor respiration continuously?
Well, technology helps. We often use impedance pneumography, which measures changes in chest electrical impedance with breathing to get a continuous respiratory rate trace on the monitor. But alongside that, pulse oximetry for oxygen saturation, say PO2, is absolutely standard. It's non-invasive, easy, but, and this is a big but, mastery means knowing when that SpO2 number might be lying to you.
Ah, okay. That's crucial. If the machine isn't giving you accurate data, you need to know why. What conditions make pulse oximetry unreliable?
There are several key pitfalls. The main ones involve abnormal types of hemoglobin, what we call dyshemoglobinemias. Think carbon monoxide poisoning or methemoglobinemia. In both cases, the abnormal hemoglobin messes with how the oximeter interprets light absorption, often giving a falsely high or uninterpretable SpO2 reading.
Okay, so abnormal hemoglobin is one issue. What else?
Certain dyes or pigments can interfere. Methylene blue, sometimes used therapeutically, can dramatically affect the reading.
And what about the patient's condition itself?
Poor peripheral perfusion is a big one. If the child is in shock and their peripheries are clamped down and cold, the sensor just can't get a good signal. Excessive venous pulsations can also interfere. And even external factors like bright overhead lights, especially phototherapy lights used for jaundice, can sometimes mess with the sensor's reading. You need to be aware of all these potential confounders.
Right, and interpreting the numbers means knowing the normal ranges, which change drastically with age.
Absolutely critical. You gave the example earlier, a 1-year-old might have a normal respiratory rate around 30, heart rate around 120. That's perfectly fine. But you see those same numbers, say RR30, HR120 in a 16-year-old. That's significant tachypnea and tachycardia. That's a sign of serious distress. You have to interpret everything in the context of age-appropriate norms. Missing that context means missing the crisis.
Okay, now let's talk about assessing perfusion at the bedside. The capillary refill time, CRT. You mentioned it's often one of the first things to go abnormal. Can you walk us through the proper technique and the threshold we're looking for?
Sure. Technique standardization is key for it to be reliable. You apply firm pressure, usually with your thumb or finger, over a bony area like the sternum or the forehead, not the nail bed, as that's less reliable. Press firmly for exactly 5 seconds to blanch the skin. Then release and time how long it takes for the normal color to return. The critical threshold is generally accepted as 3 seconds. If refill takes longer than 3 seconds, that's considered prolonged and is a very reliable sign of poor tissue perfusion, especially in children.
And this ties into another physical sign, right? The core to peripheral temperature gradient.
Yes, they often go together. This gradient tells you a lot about peripheral vasoconstriction, the body shunting blood centrally. You measure core temperature rectally or maybe esophageal and compare it to peripheral skin temp, say on a foot. If the core temp is more than 5 degrees Celsius higher than the peripheral temp, that's a strong indicator of significant hypoperfusion. The body is sacrificing the periphery to protect the core organs.
Powerful bedside signs. Now more advanced monitoring. Continuous ECG is standard. But what about central venous pressure, CVP? How does measuring that help strategically?
CVP is measured with a catheter whose tip sits in the large veins near the heart, ideally the right atrium. It essentially gives you an estimate of the filling pressure on the right side of the heart, the preload. Normal CVP, or right atrial pressure, is typically low, less than 6 millimeters of mercury. The strategic value comes in interpretation, especially alongside blood pressure. So, if a child is hypotensive and their CVP is low, it strongly suggests hypovolemia, low blood volume. The answer is likely more fluids.
And if the CVP is high?
Well, a high CVP, especially with hypotension or signs of poor perfusion, suggests the problem isn't volume, but maybe pump failure, myocardial dysfunction, or perhaps fluid overload or increased pressure in the lungs, it warns you that giving more fluids might actually be harmful.
Got it. And we keep coming back to the kidneys as an indicator. What's the definite benchmark for adequate renal perfusion?
Assuming the child has normally functioning kidneys to start with, adequate renal perfusion is generally defined by a urine output of at least 0.5 milliliters per kilogram per hour. Anything consistently below that level is oliguria, and it's a clear sign of poor perfusion. It tells you the kidneys aren't getting enough blood flow, suggesting the child is likely in uncompensated shock or heading there fast. And of course, continuously monitoring their mental status gives you that direct feedback on brain perfusion. Before we dive into the specifics of PALS and BLS, we have to really anchor our thinking in a key difference between kids and adults. Pediatric cardiac arrest is almost never a primary cardiac event, like a heart attack in an adult. In the vast majority of cases, it's the end result, the terminal event, of progressive respiratory failure or shock that wasn't recognized or treated effectively.
So the underlying cause is usually respiratory or circulatory failure.
Exactly, which means prevention, early recognition, and aggressive treatment of hypoxia and shock are absolutely paramount. The common triggers leading to arrest are things like respiratory infections, SIDs, severe sepsis, drowning, injuries. It's usually secondary to something else failing first.
Okay, that context is crucial, and it explains the emphasis on immediate standardized action when arrest does happen. The basic life support, BLS protocols were updated, shifting to CAB.
Right, circulation airway breathing. That was standardized in 2015 to ensure uniformity across all ages and to prioritize getting chest compressions started immediately. Delays in compressions are detrimental.
For healthcare providers, the guideline is really strict, isn't it?
Yeah.
If you can't feel a definite pulse within 10 seconds, start CPR.
Yes. Pulse checks, especially in infants and children during an emergency, can be difficult and unreliable. Wasting time trying to be certain about a pulse costs critical perfusion time. So the rule is no definite pulse within 10 seconds. Begin compressions.
Okay, let's talk circulation chest compressions. Quality matters immensely here.
Absolutely. You have to push hard and fast. The depth needs to be at least 1/3 of the chest's front-to-back dimension. That works out to roughly 1.5 inches or 4 centimeters in infants and about 2 inches or 5 centimeters in children.
And the rate.
The rate needs to be consistently between 100 and 120 compressions per minute. Just as important is allowing full chest recoil between compressions that lets the heart refill. And minimizing interruptions is absolutely non-negotiable. Every pause drops perfusion pressure dramatically.
The technique changes with age, too. For infants under 1, with 2 rescuers, there's a preferred method.
Yes, the 2-thumb encircling hands technique is preferred when 2 trained providers are present. You wrap your hands around the infant's chest and use both thumbs on the lower sternum to compress.
And why is that specific technique better? You mentioned it generates better perfusion pressure.
Exactly. Studies show it produces higher coronary artery perfusion pressure compared to the 2-finger method. It just seems to be biomechanically more effective at generating blood flow during CPR when you have 2 people.
Okay, and the 2-finger technique is for when?
That's used if a rescuer is alone or if they physically can't get their hands around the infant's chest. Just 2 fingers on the lower sternum.
Got it. Then for older kids, 1 to 8 years.
For that age group, you typically use the heel of one hand on the lower half of the sternum. Make sure your fingers are off the chest to avoid pressing on the ribs.
And for bigger children, over 8 or so.
For larger children or adolescents, you use the standard 2-hand method, like in adults, often interlocking the fingers placed on the lower half of the sternum.
Okay, now the compression to ventilation ratios. This seems like it depends heavily on who's doing the resuscitation.
It does, and it reflects that balance between compressions and breaths, especially given the respiratory nature of pediatric arrests. So for lay rescuers, it's simple. 30 compressions to 2 breaths, 30.2. For everyone, infants, children, adults. For a single healthcare provider, it's also 30.2 for all ages.
But when there are 2 healthcare providers?
When 2 trained providers are working together, the ratio changes for infants and children up to adolescents. It becomes 15 compressions to 2 breaths, 15.2.
Why the shift to 15.2 with 2 rescuers?
The rationale is to provide more frequent ventilations, acknowledging the high likelihood of a respiratory cause while still maintaining good compressions. It's a compromise thought to be better for kids when you have coordinated teamwork. Of course, once an advanced airway, like an endotracheal tube, is in place, compressions become continuous at that 100-120 rate, and breaths are given independently about once every 6 seconds.
Okay, let's move to airway management. You mentioned kids' airways are different, more vulnerable.
Yes, anatomically they pose unique challenges. Compared to adults, they have a smaller upper airway overall. Their tongue is proportionally much larger relative to their mouth, making it easy for it to fall back and obstruct the pharynx. The larynx is higher and more anterior. The narrowest point is the cricoid ring in younger children, not the vocal cords. And the tissues below the cords, the subglottic area, are looser and more prone to swelling. Plus, their chest wall is very compliant, floppy almost, which limits their ability to build up respiratory reserve.
So more prone to obstruction and harder to manage. What are the basic maneuvers we use?
The standard is the head tilt chin lift. Gently tilt the head back and lift the chin. This lifts the tongue off the back of the throat. It's effective unless you suspect a head or neck injury.
And if you do suspect trauma, or if their GCS is low?
Then the jaw thrust maneuver is mandatory. You place your fingers behind the angle of the jaw and lift upwards, without tilting the head back. This achieves the same goal lifting the tongue, but protects the cervical spine. It's harder to do effectively, though, which is why it's generally not taught to lay rescuers.
What about choking? Foreign body obstruction.
If it's a foreign body, the absolute rule is never perform blind finger sweeps. You're much more likely to push the object further down. Actions depend on whether the child is responsive. For a responsive infant, 1 year, it's a sequence of 5 back slaps followed by 5 chest thrusts. For a responsive older child, 1 year, it's abdominal thrusts, the Heimlich maneuver.
And if they become unresponsive while choking?
If they become unresponsive, you start CPR immediately. The only difference is, each time you go to give breaths, after your compressions, you quickly look in the mouth. If you see the object, then you can try to remove it, but still no blind sweeps.
Got it. Now, for B breathing, you mentioned agonal gasps aren't real breathing.
Correct. Those slow, noisy gasps are a sign of severe distress or impending arrest. They don't provide adequate ventilation. That child needs intervention. If a child is breathing effectively on their own and there's no trauma suspected, placing them in the recovery position helps maintain the airway and prevents aspiration if they vomit.
Okay. For providing breaths, bag mask ventilation, BMV, is the initial go-to.
Yes, BMV is the preferred first method for assisted ventilation. But you need the right size equipment. Roughly a 450-500 milliliter bag for children under 8 years, maybe a smaller 250 milliliter bag for preterm infants. The technique is key. Get a good seal with the mask, use the jaw thrust or head tilt, and squeeze the bag just enough to see the chest visibly rise.
Just visible chest rise.
Yeah.
Not trying to inflate them fully.
No, definitely not. Overinflation is dangerous. It increases pressure in the chest, which reduces blood return to the heart, lowering cardiac output. It also massively increases the risk of air going into the stomach, leading to gastric distension and potential regurgitation and aspiration. Gentle, visible chest rise is the goal.
And getting high oxygen concentration with the bag.
A standard self-inflating bag on its own only delivers room air about 21% oxygen. To get high concentrations, you must connect it to an oxygen source flowing at a high rate, typically 15 liters per minute, and use a reservoir bag or tubing attached to the resuscitation bag. That setup allows you to deliver somewhere between 60% and 95% oxygen.
Okay, that covers BLS. Moving into advanced life support, PEOS. This involves more invasive things like intubation.
PP builds on BLS. It emphasizes prevention, early detection, and then advanced management securing vascular access, treating arrhythmias, managing trauma, and, yes, advanced airway control like endotracheal intubation.
Intubation is seen as the most effective airway method, right? Why is that?
When done correctly by trained personnel, yes. It provides a secure, definitive airway. It protects against aspiration. It allows for very precise control over ventilation pressures and volumes. You can easily suction secretions, and you can apply PEEP, positive end expiratory pressure.
Ah, PEEP. What's the strategic advantage of using PEEP in these sick kids?
PEEP basically keeps a small amount of pressure in the lungs even when the patient breathes out. This helps prevent the tiny air sacs, the alveoli, from collapsing completely at the end of expiration. In conditions like respiratory distress or shock lung, this can significantly improve oxygenation by keeping more lung units open for gas exchange and preventing atelectasis, or lung collapse. It's a key tool in critical care ventilation.
Right. Now, getting intubation right means getting the tube size and depth correct. These formulas are critical.
Absolutely. Having the wrong size tube can be disastrous. For kids older than 1 year, the approximate uncuffed tube size in millimeter inner diameter is calculated as age in years divided by 4 plus 4. Cuff tubes might need to be half a size smaller.
And you always need backup sizes available.
Always. Have the calculated size, plus one size smaller and one size larger, immediately ready. Depth of insertion is just as crucial to avoid placing the tube too deep, usually into the right main bronchus. For newborns, a quick estimate for depth, in centimeter at the lips, is their birth weight in kilograms plus 6. For children older than 2 years, the depth estimate is age in years divided by 2 plus 12. These are just starting points, though. Clinical information is essential.
And how do you confirm placement? What's the gold standard check?
It's a multi-step check. First, watch for symmetrical rise and fall of the chest with ventilation. Second, listen with a stethoscope over both sides of the chest, should hear equal breath sounds. Third, listen over the stomach, you should not hear gurgling air entry. That suggests esophageal intubation, which is a disaster. Fourth, look for secondary signs: improvement in heart rate, oxygen saturation, and skin color. The ultimate confirmation is often end tidal CO2 detection using capnography, if available.
What about getting IV access during CPR, if that fails?
Time is critical. You try for peripheral IV access quickly, maybe in the largest accessible vein like the antecubital fossa or saphenous vein. But if you can't get IV access within, say, 90 seconds or after 2 attempts, you must immediately go for intraosseous IO access.
IO drilling into the bone marrow cavity. Where can you place an IO needle?
Common sites are the flat surface on the top part of the tibia, shin bone, just below the knee, the lower end of the femur, thigh bone, just above the knee, the lower end of the tibia, just above the ankle, or sometimes the anterior superior iliac spine, hip bone.
And can you give everything through an IO line? Fluids, drugs?
Yes, that's the beauty of it. The bone marrow cavity connects directly to the central circulation. You can infuse all resuscitation fluids, blood products, and critical medications, epinephrine, vasopressors, everything at the same doses and rates as through an IV. It's a life-saving bridge until you can secure definitive venous access.
Finally, post-arrest care. Resuscitation is just the start. What are the absolute priorities after getting the heart beating again?
Post-arrest care is all about protecting the brain and other organs from secondary injury after the period of low blood flow. Key goals are aggressive treatment of any fever, maintain normothermia, strict avoidance of both hypoxia and hyperoxia. We aim for normoxia, keeping oxygen saturation tightly controlled, usually between 94% and 100%. Don't overdo the oxygen. And maintaining adequate blood pressure is crucial. You need continuous arterial pressure monitoring if possible, aiming to keep the BP above the 5th percentile for the child's age to ensure good perfusion to the brain and vital organs during this vulnerable recovery period.
Okay, we've established shock is often the pathway to arrest in kids. Let's really focus on understanding and managing shock itself. Can you define it again, emphasizing that clinical aspect?
Sure. Shock is fundamentally an acute syndrome where the cardiovascular system fails to deliver enough oxygen and nutrients to meet the metabolic demands of the body's tissues and vital organs. And the critical point, clinically, is that shock is a state of inadequate tissue perfusion. It is not defined by low blood pressure. A child can be in significant shock, compensated shock while still maintaining a normal blood pressure. Waiting for hypotension means you're already behind. It's a clinical diagnosis based on signs of poor perfusion.
Right, and the main types, hypovolemic, cardiogenic, distributed.
Yes, those are the main physiological categories. Hypovolemic is loss of volume dehydration, hemorrhage. Cardiogenic is pump failure, congenital heart disease, myocarditis, arrhythmias. Distributive is widespread vasodilation, where the pipes get too leaky or floppy, think sepsis, anaphylaxis, neurogenic shock. And then there's septic shock, which is often the most complex because it frequently involves elements of all three. Hypovolemia, due to leaky capillaries, cardiogenic dysfunction, myocardial depression from toxins, and distributive shock, vasodilation.
Okay, now here's where it gets really fascinating. The body's own attempts to fight shock, to compensate. Can you unpack those complex reflexes, the neural and hormonal responses, like the body trying to maintain pressure in a failing system?
Absolutely. The body has incredibly rapid and powerful compensatory mechanisms. Let's start with the immediate neural reflexes, primarily driven by the sympathetic nervous system. You have baroreceptors, which are pressure sensors located in the walls of the carotid arteries and the aortic arch. When they detect a drop in blood pressure, they send urgent signals to the brainstem. The brainstem responds by cranking up sympathetic outflow. This causes widespread vasoconstriction tightening of the blood vessels.
But it's selective vasoconstriction, right? It doesn't clamp down everywhere equally.
Exactly. It's strategic. The vasoconstriction is most intense in non-vital areas like the skin, muscles, kidneys, and the gut, slanchnic circulation. This shunts the limited blood flow preferentially to the absolutely critical organs, the brain and the heart. coronary circulation. At the same time, chemoreceptors, located near the baroreceptors and in the brainstem, sense low oxygen levels and rising acid levels, acidosis in the tissues, which result from poor perfusion. These chemoreceptors further stimulate the sympathetic system, increasing heart rate and contractility, and also stimulating breathing in an attempt to improve oxygenation.
Okay, that's the instant neural response. What about the slower hormonal backup system?
Right. The humoral responses kick in too, providing sustained support. First, the adrenal medulla releases catecholamines, primarily epinephrine, adrenaline, and norepinephrine, noradrenaline, into the bloodstream. These hormones boost heart rate and contractility, inotropic effect, and cause further vasoconstriction, reinforcing the neural signals. Second, the pituitary gland releases vasopressin, also known as antidiuretic hormone, ADH. Vasopressin is a potent vasoconstrictor, especially in severe shock, and it also tells the kidneys to reabsorb more water, trying to increase blood volume.
And the big one for long-term volume control, the RAS system.
Yes, the renin-angiotensin-aldosterone system, RAAS, is a crucial, albeit slightly slower, hormonal cascade. When the kidneys sense reduced blood flow, they release an enzyme called renin. Renin triggers a chain reaction that ultimately produces angiotensin II. Angiotensin II is one of the body's most powerful vasoconstrictors. It also stimulates the adrenal cortex to release aldosterone. Aldosterone then acts on the kidneys, promoting the reabsorption of sodium and water, which helps to expand and maintain intravascular volume over the longer term. Understanding these layers of compensation is key to understanding shock progression and treatment.
Okay, moving from the deep physiology back to the bedside, how do we spot shock early? What are those subtle signs of compensated shock beyond just a fast heart rate?
Tachycardia is nearly always present and is often the earliest sign, but you also look for mild tachypnea, slightly faster breathing. Prolonged capillary refill time, CRT greater than 2 or 3 seconds. Subtle neurological changes can be key. Maybe the child is just a bit more irritable than usual, or perhaps slightly anxious or agitated. Sometimes you might see orthostatic changes in heart rate or BP if you can measure them, though that's often difficult in sick kids. And a really important, often early sign is a narrowing pulse pressure. That's the difference between the systolic top number and diastolic bottom number, blood pressure. As the body vasoconstricts to maintain pressure, the diastolic pressure rises, narrowing that gap. It can precede the drop in systolic pressure.
What about septic shock? Sometimes that looks different initially, this warm shock.
Yes, septic shock can be tricky. In the early phase, particularly in older children sometimes, you might see what's called warm shock or hyperdynamic shock. Instead of cool, clammy skin, they might be warm, even flushed. Their peripheral pulses might feel strong, even bounding. The pulse pressure might actually be wide. This reflects massive vasodilation, the distributive component where the blood vessels are too relaxed. Cardiac output might even be high initially, but the blood pressure is low or falling because the vascular container is too large. It's still shock, just a different presentation.
Right. And the goal is always to recognize and treat shock in its compensated stage, where BP might still be normal, but there are signs like tachycardia, agitation, prolonged CRT.
Exactly. Because if it progresses to uncompensated shock characterized by hypotension, altered mental status like drowsiness or lethargy, poor peripheral pulses, significant tachycardia, and oliguria, the risk of irreversible organ damage and cardiac arrest increases dramatically. We must intervene before they reach that stage.
Okay, so therapy starts with fluids. Aggressive fluid resuscitation. What's the fluid of choice?
The absolute first choice for initial resuscitation is isotonic crystalloids. That means normal saline, 0.9% sodium chloride, or Ringer's lactate. These fluids distribute well within the extracellular space and effectively expand intravascular volume initially. It's really important to emphasize what not to use initially. Dextrose-containing solutions. Fluids like D5W or D5 normal saline are poor volume expanders because the dextrose gets metabolized quickly, leaving mostly free water. Plus, giving a large glucose load can cause hyperglycemia, which can lead to osmotic diuresis, actually worsening dehydration. Stick to isotonic crystalloids for those initial boluses.
And the volume and speed. How much? How fast?
The standard protocol is an initial bolus of 20 milliliters per kilogram, ml/kg, of isotonic crystalloid, given rapidly, typically over 5 to 10 minutes, sometimes even faster, pushed in with a syringe if needed. After that first bolus, you immediately reassess the patient's response, heart rate, perfusion, mental status. If they're still showing signs of shock, you repeat the bolus. You can give up to 40 to 60 millicuries in total within the first hour, reassessing after each bolus.
Okay, 40 to 60 millilograms in the first hour? That's a lot of fluid. What if the child doesn't respond to that amount?
That's the critical decision point. A child who remains in shock despite receiving 40-60 millikilograms of isotonic crystalloid is considered to be in fluid refractory shock. At this point, continuing to pour in large volumes of fluid is unlikely to help and may actually cause harm, like fluid overload and pulmonary edema. This is the signal to switch gears. You need to start vasoactive medications, inotropes, or vasopressors, and ideally secure advanced monitoring like an arterial line and central venous access.
Okay, so fluid refractory shock means it's time for vasoactive drugs. This gets complex, tailoring the drug to the type of shock. Let's start with vasopressors, drugs that primarily squeeze blood vessels.
Right. Dopamine has historically been used particularly for shock, with presumably high cardiac output but low systemic vascular resistance, SVR, that warm shock profile. However, its effects are very dose-dependent. You need higher doses, typically above 10 or 15 micrograms per kilogram per minute, mg/kg, to get significant vasoconstriction, alpha effect. And its effectiveness, especially the vasoconstrictor effect, can be unreliable in infants younger than 6 months due to their immature sympathetic nervous system.
So dopamine might not be the best first choice, especially in warm shock.
Increasingly, norepinephrine is considered the preferred first-line vasopressor for warm, hyperdynamic septic shock with low SVR. It's a more potent and reliable vasoconstrictor.
Okay. What about inotropes, drugs that primarily boost heart contractility for cold shock?
For cold, hypodynamic shock where the child has signs of low cardiac output, cool extremities, weak pulses, low BP, and potentially high SVR, the goal is to improve heart function. Low-dose epinephrine, typically 0.05 to 0.3 millicg kilodramine, is often the first-line choice here. It provides potent inotropic support, beta-1 effect, and chronotropic support, increasing heart rate and contractility. At slightly higher doses, it also adds vasoconstriction, alpha effect. It's worth noting that some drugs commonly used in adults, like dobutamine, primarily an inotrope, or mid-dose dopamine for inotropy, are often found to be less effective or predictable in critically ill children compared to epinephrine.
And vasodilators. When would you use something like nitroprusside to relax blood vessels? That seems counterintuitive in shock.
It does seem counterintuitive, but there's a specific scenario. You might consider a vasodilator like nitroprusside or nitroglycerin in a child who has hypodynamic shock, low cardiac output, but also evidence of very high SVR despite adequate fluid resuscitation and inotropic support. In this situation, the heart is struggling to pump against excessive resistance afterload. Carefully adding a vasodilator to reduce that afterload can sometimes improve stroke volume, increase cardiac output, and actually improve tissue perfusion, provided blood pressure is adequate or supported by other agents. It requires very close monitoring, usually with an arterial line.
Okay, that's complex. Let's try to walk through the typical septic shock management timeline or flowchart based on the sources.
All right, so the first 5 minutes are about recognition, securing the airway and breathing, getting vascular access, and giving that first 20 milli-kg fluid bolus, also correcting any critical hypoglycemia or hypocalcemia immediately.
Then up to 15 minutes, if they're still in shock after the first 20-40 milli-kg.
If they are fluid refractory by 15 minutes, you start vasoactive support. The guidelines often suggest starting dopamine first, but as we discussed, depending on the clinical picture, warm versus cold shock, epinephrine or norepinephrine might be initiated here instead. This is also when you should be getting advanced access central venous and arterial lines, if possible.
Okay, now we're approaching 60 minutes. What if they're still unstable despite fluids and that first vasoactive drug, say dopamine? They're dopamine resistant.
If they're dopamine resistant or resistant to whichever first-line agent was chosen, the next step is typically to add or switch to a more potent agent. Usually this means starting norepinephrine if warm shock or epinephrine is cold shock, or titrating the dose of epinephrine higher if already started.
And if that doesn't work, they're now resistant to fluids and standard catecholamines like norepinephrine or epinephrine. This is catecholamine-resistant shock.
This is a very critical stage. Catecholamine-resistant shock often implies profound physiological derangement and potentially relative adrenal insufficiency, where the adrenal glands can't produce enough cortisol in response to the stress. So at this point, you must consider giving hydrocortisone stress dose steroids. And treatment needs to be highly tailored based on their specific physiology, usually guided by advanced monitoring like CVP, arterial waveform, maybe even echocardiography. If it's cold shock, low output with low BP, continue or maximize epinephrine or add norepinephrine to increase SVR and support BP. If it's cold shock but with normal BP, This suggests high SVR is the main problem limiting cardiac output. You might need to add a vasodilator, like milrinone, nitroprusside, carefully, while potentially continuing inotropic support to reduce afterload and improve flow. This requires expert management and close monitoring.
Wow, that decision point at 60 minutes really requires sophisticated assessment. What about correcting severe acidosis?
Severe metabolic acidosis, typically a pH below 7.0 or 7.1, needs to be addressed, but it's usually a consequence of poor perfusion. So the primary treatment is always to restore circulation and oxygen delivery. Sodium bicarbonate might be considered for severe persistent acidosis after ventilation and perfusion have been optimized as much as possible. Giving bicarbonate when ventilation is poor can worsen acidosis by increasing CO2 levels. It's generally used cautiously as a temporary measure if needed.
And of course, in septic shock, antibiotics are key.
Absolutely critical. As soon as septic shock is suspected, broad-spectrum antibiotics covering likely pathogens, both gram-negative and gram-positive, must be administered intravenously as quickly as possible, ideally within the first hour. Delaying antibiotics significantly worsens outcomes.
Okay, let's touch on some other advanced issues. Arrhythmias in kids during critical illness or arrest, are they common primary causes?
Not usually primary, as we said. Bradyarrhythmia, a significantly slow heart rate, is more common as a pre-terminal event in children. It's often caused by severe hypoxia, profound acidosis, or hypothermia. The underlying cause must be treated urgently. For symptomatic bradycardia causing poor perfusion, epinephrine is the most useful drug. The exception is if the bradycardia is clearly due to excessive vagal tone, like during suctioning or intubation attempts. In that specific case, atropine might be effective.
What about pulseless electrical activity, PEA? That's seeing electrical rhythm on the monitor but feeling no pulse.
PEA signifies electromechanical dissociation. The heart's electrical system is working, but the muscle isn't generating effective contractions or there's nothing to pump. It's often caused by severe reversible conditions. Management involves high-quality CPR and aggressively searching for and treating these reversible causes. The mnemonic often used is the H's and T's.
Right, the H's and T's. Let's quickly list those.
The 4 H's are hypovolemia, probably the most common, need fluids. Hypoxia, need oxygen ventilation. Hydrogen ion acidosis, needs improved perfusion ventilation, maybe bicarb. And hyperkalemia, electrolyte imbalance, or hypothermia. The 4 T's are tension pneumothorax, needs needle decompression. Tamponade, cardiac, needs pericardiocentesis. Toxins, overdose, need antidote support. And thrombosis, pulmonary embolism or coronary thrombosis. Less common in kids, but possible.
Identifying and treating one of those T's, like tension pneumothorax, can be immediately life-saving during PEA arrest.
Yeah.
Treatment otherwise is like a systole, CPR, and epinephrine while fixing the cause.
Exactly. Now, defibrillation is specifically for terminating 2 rhythms. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, VT. These are shockable rhythms.
But success depends on the state of the heart muscle.
Very much so. Defibrillation works best on a myocardium that is reasonably well oxygenated, normothermic, and not severely acidotic. That's why high-quality CPR before and immediately after the shock is crucial.
Logistics matter here too. Paddle size.
Yes. Use the largest paddles that fit on the chest without touching each other. Generally 8-10 centimeter diameter paddles for children over 10 kilograms or older than 1 year. Smaller 4.5 centimeter paddles for infants under 10 kilograms. Standard placement is anterolateral, 1 paddle below the right clavicle, the other at the cardiac apex below the left nipple. An anterior-posterior placement, one on the front, one on the back, is an alternative and sometimes preferred, especially in smaller children.
And the energy dose, it's weight-based and escalates.
Yes. The initial dose is 2 joules per kilogram, JKG. If that fails to terminate via PVT, the second and subsequent doses should be 4 J kilograms. You can increase further up to a maximum of 10 J kilograms or the standard adult dose, whichever is lower.
And the sequence is critical. Shock, then immediate CPR.
Right. The strategy emphasizes minimizing interruptions to compressions. You charge the defibrillator during CPR. Then, pause CPR briefly, deliver a single shock, and immediately resume CPR, starting with compressions, CAB, for 2 minutes or 5 cycles. Then you check the rhythm again. If VFPVT persists, you repeat the sequence. Shock at 4 J kilogram or higher, immediate CPR. Give epinephrine during CPR, consider an advanced airway. If it still persists after another 2 minutes of CPR and rhythm check, you shock again. resume CPR, and now consider giving an antiarrhythmic drug, usually amiodarone first, or lidocaine if amiodarone isn't available or contraindicated.
Okay. And we've mentioned post-arrest care, but just to reiterate the key goals again.
Aggressive fever management, maintain normothermia. Strict oxygen control, avoid both hypoxia and hyperoxia. Target SpO2 94, 100%. And maintain adequate perfusion, continuous BP monitoring. Keep BP above the 5th percentile for age. Ensure adequate urine output and mental status. Protecting the brain is paramount.
Okay, shifting gears a bit. Once a child is stabilized but remains critically ill in the PICU, ongoing care like nutrition becomes vital. They're at high risk for malnutrition, right?
Absolutely. Critical illness creates a hypermetabolic catabolic state. Energy demands go up, while intake is often reduced or impossible. Malnutrition develops quickly and negatively impacts outcomes, wound healing, immune function, ventilator weaning. So early nutritional support is crucial.
The preferred route is using the gut. Enteral nutrition, EN.
Definitely. Whenever the gut is functional, enteral nutrition is strongly preferred over intravenous parenteral nutrition. Why? It's safer, much more cost-effective, and importantly, it helps maintain the integrity of the gut lining, the mucosal barrier. It also preserves normal gut bacteria and prevents gut atrophy.
Keeping the gut working prevents complications.
Yes. Gut atrophy can lead to bacterial translocation, bacteria crossing the gut wall into the bloodstream, potentially causing sepsis or secondary infections. So, if the gut works, use it is the mantra.
How do you start EN? Slowly.
Yes. Typically start cautiously, maybe at 10-15 milliliter day of an appropriate formula, usually via a nasogastric or nasogenal tube. Then you gradually increase the rate as tolerated, monitoring for feeding intolerance like vomiting or abdominal distension.
And the feeding method, bolus feeds or continuous infusion.
Bolus feeding, giving a set volume over a short period every few hours, is often preferred if feeding into the stomach. It's considered more physiological, mimicking normal meal patterns, and can sometimes be easier to manage without requiring infusion pumps. Continuous infusion is usually necessary if feeding directly into the small bowel, for example, via NJ tube, or if the child doesn't tolerate bolus as well.
Are there times when you absolutely cannot use the gut?
Yes. Clear contraindications include things like severe gastrointestinal bleeding, recent major gut surgery where anastomosis needs to heal, or definite bowel obstruction or ileus, paralyzed bowel.
And if EN is impossible, then it's TPN, total parenteral nutrition.
Correct. If the gut can't be used for a prolonged period, TPN is necessary. This involves infusing a specially formulated sterile solution containing all necessary nutrients, glucose, amino acids, lipids, electrolytes, vitamins, minerals, directly into the bloodstream.
Does TPN require central venous access?
To provide full nutritional requirements, yes, TPN almost always requires a central venous catheter. Peripheral veins can only tolerate solutions with relatively low osmolarity, less than about 700-900 millismol, which limits the amount of calories and protein you can deliver peripherally. Central lines allow for much more concentrated hyperosmolar solutions.
And the monitoring for TPN seems intense. Why so rigorous?
Because you're bypassing all the body's natural metabolic controls in the gut and liver. TPN poses significant risks. You need to monitor blood glucose frequently, 2 to 3 times a day initially, due to the high dextrose load. Electrolytes and kidney function, urea, need checking regularly, maybe twice a week. Liver function tests, triglycerides, and blood count should be monitored weekly to watch for complications like liver dysfunction, cholestasis, or lipid intolerance. And interestingly, especially early in critical illness, the energy goal for TPN might actually be lower than for a healthy child. Overfeeding can be harmful, causing hyperglycemia, excess CO2 production, making ventilator weaning harder, fatty liver, and fluid overload. You aim for gradual advancement to goal rates.
Okay, nutrition is vital. What about keeping these kids comfortable and still? Sedation and analgesia must be a major challenge.
Huge challenge and incredibly important for humane care and facilitating treatment. The goal is safe and effective control of pain, anxiety, agitation, and unwanted movement. We need to think about the desired level of sedation. Is it moderate sedation, often called conscious sedation, where the child is sleepy but maintains protective airway reflexes and will respond purposefully to verbal commands or light touch? Or do we need deep sedation, where the child is not easily aroused, responds only to painful stimuli, and may lose protective reflexes or require airway support? The implications for monitoring and intervention are very different.
What drugs are commonly used?
For sedation, especially for kids on mechanical ventilators, continuous infusions of benzodiazepines like midazolam or sometimes lorazepam are common. Opioids like fentanyl or morphine are used for pain control, analgesia, often in combination with sedatives. Ketamine is interesting. It provides analgesia, sedation, dissociative type amnesia, and helps control movement, often while maintaining respiratory drive and blood pressure better than other agents, making it useful in certain situations. Other agents like propofol or dexmedetomidine are also used.
And sometimes you need to go further, to paralysis, neuromuscular blocking drugs.
Yes, NMBs, or paralyzing agents, are sometimes necessary but used very judiciously. Indications might be short-term, like facilitating endotracheal intubation in a difficult airway, or longer term, maybe to help with mechanical ventilation if the child is severely fighting the ventilator to synchrony, or to reduce oxygen consumption in extreme shock states, or during therapeutic hypothermia, or to manage severe muscle spasms like in tetanus or status epilepticus. But the absolute non-negotiable principle is any child receiving a neuromuscular blocker must also receive adequate sedation and analgesia. You cannot paralyze a patient without ensuring they are unaware and pain-free. And if used for seizures, continuous EEG monitoring is essential to ensure the paralysis isn't just masking ongoing seizure activity in the brain.
That's a critical safety point. Finally, in this section, let's talk about infections acquired in the PICU healthcare-associated infections, HAIs. How big a problem are they?
They are a significant problem. Estimates suggest up to 6 to 10% of children admitted to a PICU may develop an HAI. The most common types are bloodstream infections, often related to central lines, accounting for maybe 25–30%, lower respiratory tract infections like ventilator-associated pneumonia, VAP, around 20–25%, and urinary tract infections, UTIs, often catheter-related, about 15–20%.
What increases the risk?
The main risk factors are the severity of the child's underlying illness, the length of their PICU stay, and crucially, the use of invasive devices and monitoring. Something like 90% of bloodstream infections are linked to central venous catheters, and around 95% of pneumonia cases in the PICU are associated with mechanical ventilation. These devices breach natural defenses.
So prevention strategies are key. What works?
Basic infection control is paramount. Meticulous hand hygiene by everyone, using aseptic technique for all invasive procedures. Prioritizing enteral nutrition helps maintain gut health, as we discussed. And then there are specific bundles of care targeting common HAIs for VAP prevention, keeping the head of the bed elevated 30–45 degrees, using cuffed endotracheal tubes when appropriate, regular oral care, and perhaps judicious changing of ventilator circuits, though evidence on frequency varies. For preventing bloodstream infections, strict protocols for central line insertion and maintenance, including sterile barriers, chlorhexidine skin prep, careful dressing management, for example, transparent dressings, and minimizing the use of multi-lumen catheters or unnecessary line access.
All right, let's tackle blood product transfusions. This is another high-risk area requiring precise knowledge. Starting with red blood cells, RBCs. When do critically ill children typically need red cells? What are the triggers?
The indications for RBC transfusion vary quite a bit depending on the clinical context, the child's age, and how well they're compensating. There isn't one single hemoglobin trigger. It ranges from, say, an asymptomatic, stable infant whose hematocrit drops below 20%, potentially needing a transfusion, all the way to a child actively showing signs of inadequate oxygen delivery, like severe hypoxia, acidosis, or altered mental status, where transfusion might be considered even with a hemoglobin level as high as 6 or 7 GDL, or maybe even higher if they have cyanotic heart disease. Specific situations also have thresholds, like needing transfusion for malaria with hyperparasitemia, over 20% infected RBCs.
And how much do you typically give? What effect does it have?
A standard dose is usually 10 to 15 milliliters per kilogram, ml/kg, of packed red blood cells, which have a hematocrit around 70–75%. Giving 10 ml/kg will typically raise the recipient's hemoglobin by about 2.5 GDL.
Is there a concern about giving it too fast, especially in certain kids?
Yes, particularly in children with chronic anemia, who may have adapted to a lower blood volume and whose hearts might be strained. In these cases, transfusing too quickly can cause circulatory overload and precipitate heart failure. So for chronic anemia or concern for cardiac function, the transfusion needs to be given much more slowly, sometimes split into smaller volumes.
Compatibility is obviously crucial. What are the key rules?
Basic ABO compatibility is essential. The recipient's plasma must not contain antibodies against the donor's A or B antigens. So Group O donors are universal RBC donors, Group AB are universal recipients. RHD compatibility is also vital. RHD-negative recipients must receive RHD-negative RBCs to prevent sensitization, especially important for girls and women of childbearing potential.
And there are strict time limits for administration.
Yes. Once a unit of RBCs is removed from controlled refrigerated storage, usually 6 degrees C, the infusion must begin within 30 minutes, and the entire infusion must be completed within 4 hours to minimize the risk of bacterial growth in the unit at room temperature.
Okay, moving to other components. Platelets. What's different about them?
Platelets are crucial for blood clotting. Units collected by apheresis from a single donor are typically larger, containing about 3 by 10^11 platelets. Unlike RBCs, platelets are stored at room temperature, 20-24 degrees C, with continuous agitation, but only for about 5 days, which makes inventory management tricky.
When do you give platelets? What's the threshold?
Indications depend heavily on whether the child is bleeding and the underlying reason for the low platelet count, thrombocytopenia. Generally, a platelet count below 10,000 per microliter, 10 by 109 L, almost always warrants transfusion due to high risk of spontaneous bleeding. For invasive procedures or major surgery, the target is usually higher, needing counts about 50,000 or 60,000, 50-60 by 109 L. Platelets are typically infused relatively quickly, often over 20 to 30 minutes.
What about plasma? Fresh frozen plasma, FFP.
FFP is plasma that's frozen shortly after donation, preserving all the coagulation factors, including labile ones like factor V and factor VIII. It contains about 0.7 units ml of factor VIII. Its main use is to replace multiple coagulation factors in patients who are bleeding due to deficiencies, such as in severe liver disease, disseminated intravascular coagulation, DIC, with active bleeding, or sometimes warfarin reversal, especially if specific factor concentrates aren't available.
Does FFP need to be ABO compatible?
Yes, FFP contains ABO antibodies, so it must be ABO compatible with the recipient's red blood cells to avoid hemolysis. A typical dose is 10-20 millisecond, which usually raises coagulation factor levels by about 20%.
And cryoprecipitate, what's in that?
Cryoprecipitate is a fraction derived from FFP when it's thawed under controlled conditions. It's a concentrated source of specific clotting factors, mainly fibrinogen, 100 to 250 milligrams per unit, factor VIII, von Willebrand factor, VWF, and factor 13. Its use is more targeted, primarily for treating bleeding due to low fibrinogen levels, hypofibrinogenemia, or sometimes in hemophilia A or von Willebrand disease if specific factor concentrates aren't available. A typical dose is about 1 unit per 510 kilogram body weight.
Okay, we've covered the components. Let's end with the risks. Transfusions aren't benign. What are the major dangers?
No, they carry significant risks. Major categories include transmission of infectious agents, though risk is very low now in developed countries due to screening. It includes HIV, hepatitis B, C, syphilis, malaria in endemic areas, CMV, etc. Bacterial contamination of the unit itself, especially platelets stored at room temp, and importantly, transfusion reactions.
Transfusion reactions, how do we differentiate mild from severe?
Reactions range widely. Mild reactions often involve itching, pruritus or hives, urticaria, maybe slight fever. These are often managed by slowing the transfusion and giving antihistamines, then potentially resuming cautiously. Life-threatening reactions are medical emergencies. These include acute intravascular hemolysis, usually due to ABO incompatibility, anaphylaxis, severe allergic reaction, transfusion-related acute lung injury, TRLRI, or severe febrile non-hemolytic reactions causing significant distress or hypotension.
If you suspect a life-threatening reaction, what's the immediate drill?
Immediate action is critical. First, stop the transfusion immediately. Second, keep the IV line open with normal saline using a new IV tubing set. Don't flush the old line. Third, notify the physician in the blood bank right away. Fourth, assess and support airway, breathing, circulation. Provide supplemental oxygen. Fifth, if hypotension is present, give a rapid 20 millilg saline bolus. Sixth, for suspected anaphylaxis or severe reaction, administer epinephrine, 0.01 mg/kg, usually IM or SC initially. Steroids and bronchodilators might also be needed depending on symptoms. The remaining blood product and patient samples need to go to the blood bank for investigation.
And one final complication, massive transfusion. What happens when you give huge volumes of blood quickly?
Massive transfusion, often defined as replacing the child's entire blood volume, roughly 80 to 90 mg/kg, within 24 hours, or replacing half the volume within a few hours, brings its own set of metabolic problems. These include acidosis from the stored blood and poor perfusion, hypothermia, infusing cold blood rapidly cools the patient, hyperkalemia, potassium leaks from stored red cells, citrate toxicity. Citrate is the anticoagulant in blood bags. Large amounts combine calcium, leading to hypercalcemia, and dilutional coagulopathy, replacing whole blood with packed RBCs, and crystalloid dilutes clotting factors and platelets. Managing massive transfusion requires anticipating and treating these complications proactively. Hashtag outro. So we've really journeyed across the entire landscape of pediatric critical care today, from the physical necessity of having 250 square feet per bed, delving deep into the body's intricate neural and hormonal responses to shock, all the way to the precise logistical mastery needed for every fluid bolus, every drug calculation, every unit of blood components. True mastery in this field, it really means constantly linking that sharp ABCDE assessment to the right, time-critical intervention, whether it's a PAL-LS algorithm, a specific shock protocol, and always anticipating those potential downstream complications like healthcare-associated infections or the metabolic tightrope walk of TPN. It's about connecting all those dots constantly.
Absolutely. And hopefully for you listening, this deep dive provides that high-level framework, that strategic map used by elite professionals navigating one of medicine's most challenging and ultimately rewarding fields. You now have a better grasp of the principles guiding decision-making when the stakes are incredibly high. So here's a final thought for you to consider, building on what we've discussed. We established that the vast majority of pediatric cardiac arrests stem from progressive respiratory failure or shock, often triggered by underlying conditions like severe pneumonia or severe malaria conditions mentioned right in the admission criteria. Now, imagine a world with significantly improved basic pediatric preventative care and infection control globally. How fundamentally might that kind of public health success reshape the entire landscape of pediatric critical care? Would it change the required capacity, the operational focus, the very nature of PICUs worldwide? That's a big question linking critical care back to global health strategy. Thank you for joining us for this deep dive. We'll see you next time.